Greetings. My name is Ayalou Teferi, and I'm a professor of medicine and hematology at the Mayo Clinic, Rochester, Minnesota. And I'm here to highlight the key findings in a 1,000 patients study in primary myelofibrosis, a study that is scheduled to appear at the Mayo Clinic Proceedings issue of January 2012. The study is the largest of its kind and is further distinguished by the fact that over 95% of the patients have had cytogenetic information at the time of their diagnosis. The first key finding is the fact that when patients with myelofibrosis present, their clinical features are not at a stable state and usually progress within the first few months of their diagnosis. This is not a trivial matter because it affects how accurate the prognostication is for each individual patient. In other words, it is best to wait for a few months after diagnosis before providing a prognostic score for a particular patient. The second finding is the fact that the most recent revision of the International Prognostic Scoring System, the so-called DIPS Plus prognostic system, performed much better in discriminating between different risk groups. And this is probably because DIPS Plus includes cytogenetic information in its prognostic evaluation. The third key finding is the fact that many patients with primary myelofibrosis can live a very long life, and in fact patients with low risk has an average survival that exceeds 15 years. Also, in young patients, even if they are intermediate 1 risk disease, they can expect a median survival that approaches 15 years. On the other hand, DIPS Plus allows us to identify patients in whom survival is shorter than 5 years and in whom allogeneic stem cell transplantation is most suitable for. The fourth finding is actually an important finding in terms of management, and it tells us what proportion of patients with this disease are suitable for what therapy. In general, more than 50% of the patients are usually present in a manner that requires simple observation alone or utilization of some conventional therapy. Among the other 50%, only half will have disease features such as massive splenomegaly or profound constitutional symptoms that would require an anti-cytokine therapy such as the newly approved ruxolitinib, which is a JAK1, JAK2 inhibitor. 25% of the patients might require consideration of allogeneic stem cell transplantation earlier than later. In other words, the newly approved ruxolitinib in patients with myelofibrosis is probably appropriate in no more than 20% of patients with this disease. The last and most important conclusion that can be made from our large study is the fact that one has to understand the natural history of a specific disease in order to justify a specific treatment recommendation, and also in order to design a clinical trial with endpoints that are relevant to patients rather than drug companies.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.